This is a video illustration of a frontotemporal craniotomy in a 9-year-old boy who had presented to us with headache and drowsiness. His MRI brain with and without contrast showed a large contrast-enhancing lesion causing significant mass effect. He was placed supine with head fixed in Mayfield clamp. Patient was registered on neuronavigation. After the frontotemporal craniotomy, a curvilinear opening of the dura was obtained. This was followed by the identification of the tumor, which was rather easy from the rest of the brain parenchyma. A combination of microsurgical techniques were used to gradually debulk this tumor. A familiar sequence of bipolar coagulation, followed by the use of microscissors as well as larger medicine balm and Mayo scissors to remove this large ugly tumor in a piecemeal manner. Here you can see I'm using a bipolar coagulation forceps to devascularize the tumor, as it was seen to obtain blood supply at the skull base from the dura, and combination of coagulation and sharp cutting is used to devascularize this tumor. Here you can see the tumor being gently pulled by the use of coagulation and suction from its attachment to the falx cerebri. The tumor is seen to be extending under the free margin of the falx cerebri to the contralateral side. In doing so, we are devascularizing the tumor. You can see further tumor being delivered from its attachment at the skull base. Again, you can see once the tumor is effectively devascularized by decreasing its blood supply from the falx as well the dura, it was rather easy to remove this tumor piecemeal by delivering and cutting large pieces of the tumor. It's quite fleshy, if I may say. There were areas within this tumor which were still highly vascular and invited the use of our coagulation device. Again, you can see this familiar sequence where I'm using cotinoids to develop the interface or exploit the interface between the tumor and the normal brain parenchyma, and then coagulating the tumor and cutting it down into small pieces with the help of scissors, then resecting and removing those pieces from the surgical field. In this case, this tumor was quite large, as you can imagine and see for yourself, that just kept on coming to the surgical field. The more we removed, the more kept coming. Here you can see the arachnoid being dissected around the area of the optic nerve on the right side, and then using the arachnoid to deliver the tumor without causing any damage to the surrounding critical neurovascular structures. The tumor was sort of lobulated. It was rather helpful as it aided us in the resection of this large ugly tumor. Here you can see the tumor being delivered from underneath the falx cerebri by gently pulling it with the use of bipolar coagulation forceps and suction, sometimes with the use of tumor biopsy forceps. Most important was not to cause any damage to the normal brain parenchyma as well as the branches of the ACA in this region. And we resorted to rather removing this tumor piecemeal. Very good illustration of the plane between the tumor and the brain, where more tumor is delivered and it just kept on coming from underneath the falx cerebri. And using the familiar sequence of bipolar coagulation and following it up with scissors to remove this tumor, and sometimes using my bipolar as a scissor, coagulating and cutting the tumor. Parts of the tumor were vascular as well. Again, coming to the area of the optic chiasm, this time to decrease the tumor which is attached to the optic chiasm and the optic nerve, as well as the anterior wall of the third ventricle in the area of lamina terminalis and the bilateral thalami, exploiting the arachnoid to help us with the dissection of tumor of these critical neurovascular structures. See the optic nerve on the contralateral side as well. The tumor is gently pulled off its attachment via the arachnoid's membrane to the optic nerves bilaterally and the optic chiasm. Here you can see I'm using bipolar coagulation forceps in my left hand and using it to shred the tumor into smaller pieces and remove it, which of course is best for safety purposes. Time was spent to deliver this tumor in small pieces and not damage the optic nerves or the optic chiasm as well as the thalamus posteriorly. Again, the tumor was delivered from underneath the falx, and this is the last part of the tumor as its attachment is being coagulated and cut in the region of the inferior sagittal sinus. You can easily see the floor of the middle cranial fossa seen on the contralateral side. Hemostasis starts with the use of small pieces of surgical to cover the nude brain, and this was followed by the placement of cotton balls to achieve satisfactory hemostasis. The dura was closed, watertight, and then supplemented with a pedicled pericranial graft in an area which was tenuous and needed a repair. The epidural space was obliterated by the placement of tack-up sutures and epidural plane was epidural plane was This is the post-op MRI with and without contrast, which shows a gross total resection of this brain lesion. Thank you.